So intraspinal extension is not very common in neuroblastoma, but still it's common enough and a problematic thing for us to realize that it's there and act accordingly. The reported prevalence is around 15%, and around 65% of these are symptomatic representation. They usually have a lower age at diagnosis. They are more commonly seen with thoracic tumors. Fewer of them are metastatic at presentation, and more of them have a favorable histology, with very few having NMIC amplification. And therefore, overall survival and event-free survival in these patients with intraspinal extension is better than other neuroblastomas. But then a lot of these patients, as we'll see along this talk, have long-term problems which they have to cope up with. So the intraspinal extension induces the spinal cord and or the root canal compression with the symptoms. The neurologic, motor, and sensory deficits may develop. Sphincter dysfunction, which includes the bladder and bowel dysfunction, could be there, and obviously there could be root pain. And this requires prompt intervention to prevent irreversible neurologic damage, which would happen if delays happen in this. So all of us consider that intraspinal extension is probably considered as an IDRF, but it's not true. They are considered to be an image-defined risk factor only if the tumor occupies more than one-third of the spinal canal, as seen in this picture here. Not like in this picture down there, where less than one-third of the spinal canal is occupied. It could also be an IDRF if the perimedullary leptomeningeal space is obliterated, as in this patient here, where you cannot see the leptomeningeal space, or the spinal cord intensity, signal intensity is altered, as seen here in this patient. So when these conditions are there, then it is considered as an image-defined risk factor. Most of these patients are staged as L2 unless they're metastatic, and neoadjuvant chemotherapy is given to all these patients for the treatment of the neuroblastoma. The symptomatic cases and asymptomatic cases all get chemotherapy. But chemotherapy does not ensure regression of the IDRF. That means that resection of these tumors still may be far call. The optimal strategy to treat these patients is still unclear. It could be neurosurgical decompression by a laminotomy or a laminectomy, radiotherapy, or chemotherapy. And what is not clear again is the treatment of residual tumor after the chemotherapy has been given, as many reports are there in which this residue is left alone and it doesn't cause any problem. But what is more important for us to realize is that any kind of treatment we give to these patients are associated with long-term morbidities. So the disease itself is associated with long-term morbidities, and the treatment we offer is also associated with long-term morbidities. So there has been a changing trend in the strategy for treating these patients. As you see, before 2000, a lot of these patients underwent neurosurgical intervention, while now after 2000, more and more of these patients are undergoing chemotherapy. We have seen from many reports that neurosurgical intervention or radiation therapy is a straightforward risk factor for spinal deformity. And it has been shown that there are less sphincter dysfunction in those who are treated with chemotherapy as in comparison to neurosurgery. And that is why there has been a changing trend towards chemotherapy for these patients. Now, looking at the various problems in the treatment modalities, with the neurosurgical intervention can lead to progressive spinal deformities and also orthopedic problems like scoliosis and kyphoscoliosis. Sometimes during the intervention, there is spinal cord ischemia, which can lead to complete paraplegia. Radiation therapy leads to problems of growth and development, again leading to scoliosis. And when it is given in the upper thoracic and cervical region, it can lead to thyroid problems. Chemotherapy is also not bereft of any problems. Most importantly, it doesn't lead to any immediate relief. As we all know, these drugs have special problems like autotoxicity, cardiotoxicity, and second malignant neoplasms. But anyway, this chemotherapy has to be given for the treatment of neuroblastoma with or without the intraspinal extension. And so, when we give it for intraspinal extension, it doesn't add any more to the morbidity. It was Hayes et al. In 1984 who pioneered the use of chemotherapy for intraspinal extension in neuroblastoma, and thereon it gained more and more popularity, so that now it is the main mode of therapy for these patients. The 5-year overall survival for these patients has been reported to be 81%. It is much better than it used to be. After 2000, the OS has been about 86%. But as I mentioned earlier, nearly 60% of these survivors have long-term problems. So, looking at the various deficits which occur because of intraspinal extension, we see that the motor deficits, which are usually 85% patients have this at presentation, decreased to around 50%, bladder dysfunction from 37% to 25%, and bowel dysfunction from 30% to 16%. But still, at the end, at the follow-up, you see a significant number of these patients will have these deficits, which they have to deal with for their whole life. The severity of motor deficit at diagnosis is most predictive of the ultimate motor outcome, the spinal deformity, and also the sphincter dysfunction. And the sphincter dysfunction at diagnosis directly correlates with the long-term sphincter dysfunction. Now, looking at the outcomes of these patients, there has been no significant difference between neurosurgical and chemotherapy in the relief of neurological deficits. So significantly more motor deficits are seen after neurosurgery, and significantly less bladder dysfunction is seen after chemotherapy. Long-term spinal deformity, as I mentioned earlier, is strongly associated with neurosurgery and radiotherapy. And therefore, chemotherapy is preferred over neurosurgical intervention or radiation therapy in the treatment of these patients. What has been our experience at AIMS? In this period from 1996 to 2014, we had 264 cases of neuroblastoma, of whom 29 had intraspinal extension, that is a prevalence of 11%. And as in the literature, 69% of these patients were symptomatic. The median age was 30 months, and thoracic location was in 48% of these patients. But unlike the literature, we had a sizable percentage of these patients, 45%, who were metastatic disease at presentation. Neurologic symptoms, which were seen in 69% of the patients, constituted motor deficits in 80% of the patients, bladder and bowel dysfunction in 50% of the patients, and pain in 10% of the patients. Onset to diagnosis duration is a very important parameter for recovery of these patients. The median in our study group was 60 days, and nearly 90% of our patients had a duration of more than 4 weeks, which is the cutoff for having better outcome. But a lot of our patients presented late with long durations of symptoms. Treatment that we had offered, that we had given 90% of the patients chemotherapy. The symptomatic amongst them, nearly all of them got chemotherapy. Neurosurgery followed by chemotherapy was done in 3 patients, that is 10%, and none of them received radiotherapy upfront. The recovery in our patients, out of the 20 patients who were neurological deficits, nearly 35% of them had complete recovery and 50% partial recovery. So at the end, during the follow-up, 80% of patients were ambulatory without support, but 80% of the patients had more or less recovered the sphincter dysfunction. And in spite of those patients having more than 4 weeks of onset of symptoms to the diagnosis, duration of more than 4 weeks, nearly 35% of them achieved complete recovery of neurologic deficits. The overall survival in our study group was 93%, disease-free survival was 59%, and there were 33% of the patients who are surviving with stable disease with no evidence of malignancy or any progression. Unfortunately, 3 of our patients are in end-stage renal disease at the last follow-up that we had with patients. So to conclude, the reported prevalence of intraspinal extension neuroblastoma is around 15%. 65% of these are symptomatic at presentation. Literature is still unable to guide treatment. Initial chemotherapy is probably the best strategy. The burden of long-term health problems in survivors is around 60%, which is quite high. And it has been difficult to compare results because of heterogeneity of the population induced, included the absence of treatment guidelines, the lack of uniformity in terminology, and the differences in the long-term follow-up. We know that spinal deformity tends to aggravate during puberty. So if the follow-up is short, then the incidence of long-term problems will be short. So more well-designed studies are required to answer all these questions. But until that time, We should have a high index of suspicion for neurological symptoms as presenting symptom for intraspinal extension. We should probably treat all these patients with chemotherapy and limit neurosurgery only for rapidly deteriorating patients or patients who do not respond. And we should have a long-term targeted follow-up of these patients to tackle their multiple problems. Thank you.